Myself, I'm Dr. Dinesh, one of the mentor of Team StudyMEDICS. Today, we are welcoming you on this beautiful evening on the topic of endometriosis and subfertility, which is dealing with the subfertility module of your MRCOG Part 2 syllabus. Subfertility, which is very important, very essential, and yes, it is very concise topic that one should be understanding in detail in an order to attempt for your MRCOG Part 2 journey, also to help out the infertile couple in an order to achieve
Recording in progress.
So today we are going to discuss about a very important topic, that is endometriosis, which is a very important ASHRAE guidelines. Yes, based on that, there is a very recently been applied a TOG article is available. So we are going to discuss about very important aspect about endometriosis in context to subfertility and some questions which is related to it. So let's start the session with a beautiful quote. Life begins at the end of your comfort zone. You create your reality. Once you are coming out of the comfort of whatever the luxury we have, today might be the scenarios where you are preparing and struggling hard for your MRCOG Part 2 preparation, balancing your professional life, balancing your personal life, and dedicating yourself more into your academics for your MRCOG Part 2 journey. But yes, this hurdle and hazards will be for a couple of few more days. And once the exam is done, then definitely you're out of it and you'll be shining with the bright color of success. And to make it very easier note, we are having this RRR series dedicated to a very important modules which is related to your part touch about very important topics which are exam essential. So let's deal with the topic of endometriosis. Let's talk about the prevalence of endometriosis. Women of the reproductive age in the United Kingdom is approximately 10% are affected with the endometriosis, and those are having the subfertility as a concern. In that population, 25 to 50% patient diagnosed with the problem of endometriosis. What is endometriosis? It is defined as endometrial tissue which has the ectopic glands and stroma found outside the uterus. New European Society of Human Reproduction and Embryology guidelines recommends that laparoscopy is no longer considered as a gold standard. Previously, in order to diagnose the endometriosis, the laparoscopy is always considered as a gold standard by means of supplementation with the histopathological examination. Laparoscopy should only be performed in a patient with a negative imaging and or where the empirical treatment was unsuccessful or inappropriate. As highlighted by the current ASHRAE guidelines, the imaging modality in the form of MRI, that is magnetic resonance imaging, and the advanced ultrasonography are considered as the first-line investigation even for the cases of deep endometriosis. When we are discussing about the mechanism of endometriosis in context to subfertility, there are certain couple of things that we should be understanding. In order to achieve the pregnancy, unprotected sexual timely intercourse matters. If the couple is getting dyspareunia, the intercourse-related difficulties, definitely the frequency will not be that like a normal couple, and yes, it might put them into the subfertile category. Because of the endometriosis, the anatomical distortion will happen, and that will be again leading to the subfertility. 30% cases will diagnose to have the tubal pathology. We know that when the endometriotic tissues are going into the ovarian tissue, that is called as endometrioma, and it is also considered as one of the severe marker of disease. The space occupying effect of that endometrioma causes the oxidative stress in relation, which leads to the fibrosis, loss of cortical stroma, smooth muscle metaplasia, impaired vascularization, and at later stage, reduced follicular maturation and atresia in early follicles. And that leads to the poor quality of oocyte, poor quality of fertilization, poor quality of embryo formation, and poor implantation, which in turn result into infertility. As it affects the quality of egg, but the studies have demonstrated that there is a higher rate of aneuploidy in those who are affected with endometriosis, which is not shown with any studies so far. But yes, quality gonna get hampered with it. Because of the subfertility and endometriosis as a concern, understand that endometrial synchrony get hampered, and yes, endometrial receptivity will also be hampered. Endometriosis is something which is a chronic inflammation and that affects the endometrial receptivity, also the progesterone sensitivity. In that order, we need to opt for the frozen embryo transfer if you are opting for the embryo transfer. During the endometriosis causing the inflammation, it has been seen that there is increased induction of P450, that is cytochrome aromatase excretion, and that leads to the poor IVF outcome. Also, because of the endometriosis, there could be a possibility of going through the pelvic surgery in order to get a symptomatic relief because of endometriosis, and that in total decreases the ovarian reserve if the surgeries are associated with the ovary. And that how it decreases the ovarian reserve. Understand, a patient going for endometriotic cyst excision or such a surgery in that context, get documented ovarian reserve pre-surgery and post-surgery in order to understand the effect of the surgery on the ovarian reserve, so that patient can channelize their further fertility options. In order to do a staging and scoring of endometriosis, in popularity, there are three systems of classification. The first, the Revised American Society of Reproductive Medicine, which is historically called as American Fertility Society or AFS, and that scoring system is Revised ASRM scoring. It is designated to classify the extent of the disease and its relationship with the pregnancy. However, it does not correlate well with the pain or subfertility. The NZN scoring system, which is applied to the pre-operative imaging assessment so as to predict about the laparoscopic operating time, but it has no or very little correlation with the patient's symptoms and infertility. A very recently been very well popular, that is Endometriosis Fertility Index, that is EFI. Point scoring system, which is grouped into 5 categories of risk to predict the pregnancy rate in a woman with surgically assessed endometriosis who are in the patient who are attempting for the non-IVF conception. So the post-surgery, how likely chances of this couple to have a conception spontaneously, and that can be documented well by means of endometriosis fertility index. When it comes to the ASRM scoring system, where the patient's symptoms are more, but subfertility is such a symptom which can't be scored well. The pain can be scored by means of the scoring system of 0 to 1 to 10, or adhesions can be scored well. And that's the reason in current Asian recommendation also, endometriosis fertility index always gives the advantages. How to deal with the management of endometriosis related to the subfertility if the couple is willing for spontaneous conception? The Asian guidance is that the ovarian suppression should not be prescribed to improve the subfertility related to endometriosis. We know that that is combined with contraceptives, the progesterone will be given to the patient in order to have a symptomatic relief of a patient of endometriosis. If the patient is complaining about pain, patient is complaining about dysmenorrhea, dyschezia, dyspareunia, in that context, definitely you can give a ovarian suppression and that will be giving a symptomatic relief. Even in the post-operative phase, in order to avoid the recurrence of endometriosis, such a suppression will be given. But if it in context of subfertility, it is not recommended. Laparoscopy could be offered as a treatment for the endometriosis related to subfertility for early stage endometriosis and improves the rate of ongoing pregnancy. In a surgical, we should not be prescribed with an intention to improve the fertility, but reserved for a post-operative pain management in a woman that may not be seeking to conceive immediately after the surgery, with the knowledge that this is not a detrimental. The Asian guidance is that the surgery for deep endometriosis does not definitely improve the fertility, but may be an option in a symptomatic woman wishing to conceive. When it comes to the assisted conception, in assisted conception, it could be an IUI or it could be an advanced version, that is IVF, or it could be a superfine version of ICSI. So talking about the IUI with the ovarian stimulation could be offered as a treatment option if all other factors, for example, the ovarian reserve, maternal age, patent tube, semen qualities were in favor. The success of IUI in a woman who are less than 40 is low, and the live birth rate per cycle is less than or equal to 4% in the recent systematic review, and therefore IVF should be considered as the first line in this woman. In women with endometriomas, the antral follicle count to the ovarian response rather than the AMH. And AMH could be one of the misleading over here. Antibiotics are recommended as a good practice for a woman with endometriosis undergoing with ART procedures like OM pickup, as they are considered to be having a higher risk of pelvic infection. So whenever your patient is having endometriosis, going with the IVF cycle, in IVF stimulation followed by oocyte retrieval. In oocyte retrieval procedure, the needle is passing through the endometrioma and sometimes it might transmit the infection. And in order to avoid a further sepsis-related consequences, it is far better to provide the antibiotics. If the woman's opt for the fertility preservation after a counseling, she should be aware that the two main factors impacting the live birth rate, the number of oocytes vitrified and the age of the patient. If the age is on a higher side and the oocytes are vitrified, which is average or below average, understand with the advancing of the age, the oocyte quality get deteriorated. And having the condition of endometriosis, that itself puts the patient to have the bad quality of oocyte. So it is recommended that women who are less than or equal to 35 years of her age should cryopreserve at least 10 to 15 oocyte to achieve the live birth rate between 40 to 70%. Let's discuss about the treatment option for the endometriosis. If it is a minimal or mild endometriosis, what about medical therapy? No improvement has been seen in terms of natural conception. Medical therapy, where the COCs, the GnRH agonists, the progesterone, the hormonal suppression is given as a contraceptive options too. Surgery. In terms of surgery, the chances of natural conception could be considered good in a good prognosis patient. When we are talking about such a prognosis, the age, ovarian reserve, tubal patency, semen quality, this all will be counted enough. And that's the reason if a couple is having minimal mild endometriosis, planning for a natural conception, yes, you can give an option of surgery. Assisted conception does not reduce the success of ART as compared to the women who are not having endometriosis. So it is again win-win situation in both the cases. Talking about moderate to severe endometriosis, in such cases, there is no improvement of natural conception, post-operative suppression prior to the ART used to prevent the symptom recurrence, but not to increase the live birth rate, not even increase the chances of conception. Surgery may increase the natural conception in a moderate to severe endometriosis, but understand the fact that when it comes to the assisted reproductive technology, has a greater chances of success. And consider asymptomatic women with a previous failed IVF balancing the increased risk of surgical complications and reduction in ovarian reserve after the surgery. In that context, always prefer to go for ART cycles. When it comes to the assisted conception, it is associated with a lower number of eggs retrieved and it decreases the live birth rate following the ART. But yes, as compared to the surgery, this ART will be always one of the good option. A localized collection of the endometrial tissues into the ovary forming the endometrioma. In that context, medical therapy like a dynogen suppression may have a less impact on the image. It is one of the good therapy. Talking about the surgery, what are the surgical options you'll be considering? Cystectomy may carry the risk of decreasing the ovarian reserve. Cystectomy has advantages of preventing a recurrence. So routine cystectomy does not increase the live birth rate with the ART cycle. Consider surgery if the access to the oocyte during the retrieval procedure is difficult, then yes, you can go with the endometrioma surgery. The cutoff is 3 cm and above. You can think about operating endometrioma. So endometrioma, which is more than 3 cm, that is 30 mm and above, has a significant negative effect on the number of oocyte collected. Cystectomy increases the risk of poor ovarian response to the stimulation. Because in an order of cystectomy, there is a depletion of the oocytes, there is a decrease in the ovarian reserve, and that's the reason in an infertility context, patient having endometriosis, going for a ART cycle, we never advise to go for surgery, but surgery will be only recommended when access to the oocyte will be difficult. As a precautionary step in an order to avoid infections in such a oocyte retrieval or in such a home pickup procedure, you need to give for the antibiotics. So in crux, if you see this TOG article about subfertility and endometriosis is the crux of your ISHRE guideline. Please go through this TOG article. It will be help you a lot if you are not able to recollect or if you are not able to read out complete ISHRE guideline, which is more than 100 pages and above. So let's come up with the questions over here. So the question about which of the following statement is false. So talking about this question, the first option is the extended administration of GnRH agonists prior to the ART treatment to improve the live birth rate in infertile women with endometriosis is recommended. As we have recently read up into the line that yes, it is not recommended and it is a false statement. Definitely we are coming closer to the option. There is insufficient evidence to recommend prolonged administration of COC, progesterone, pre-treatment to the ART to increase the live birth rate. Yes, true. The clinician should not routinely perform a surgical excision and ablation for an incidental finding of asymptomatic endometriosis at the time of surgery. Definitely such a surgical excision definitely going to deplete the ovarian reserve. D, in infertile couple or in woman with a revised ASRM stage 1 and stage 2 endometriosis, Clinicians may perform intrauterine insemination with ovarian stimulation instead of expectant management or IUI alone, as it increases the pregnancy rate. Definitely in stage 1 and stage 2, you can. Endometriosis is associated with a higher risk of ovarian, breast, and thyroid cancer. In particular, the increased risk of absolute risk compared with the woman in general population is low, but no significant overall increases. But yes, such a minute increase in risk just because of it is one of the estrogen predominant condition. And yes, here becomes with the answer, that is A. As we know that the extended administration of GnRH agonist prior to the ART treatment to improve the live birth rate in infertile women with endometriosis is not recommended as the benefit is uncertain. And there is insufficient evidences to recommend a prolonged administration of COC, progestogens, and as a pre-treatment to the ART to increases the live birth rate. In an infertile woman with ASRM revised 1-2, clinician may perform IUI, that is assisted reproductive techniques, one of them. Instead, the expectant management or IUI alone in a spontaneous or non-stimulated cycle. Endometriosis do have a risk of ovarian, breast, and thyroid cancer. And the absolute risk compared to the general population is still low, but yes, the risks do exist, but there is no significant overall increase in risk. And it is not routinely to perform excision in an asymptomatic woman as per the Endometriosis Revised Guideline 2022. Moving ahead with the next question. 34-year-old Paris woman was diagnosed with stage 3 endometriosis. She was on GnRH agonist analog for a 1-year duration. Subsequently, she had laparoscopic excision of rectovaginal endometriosis. She continues to be on pain despite of medical and surgical management. It is a severe endometriosis or rectovaginal endometriosis which is refractory to the medical and surgical management. What is the most appropriate management options for her? If you see your HRA guidance, very clearly it is mentioned rectovaginal endometriosis, which is refractory to the medical and surgical management. In that context, yes, you can consider your patient for the aromatics inhibitor. Danazol is nothing but an anti-androgen. And if you're giving a danazol to a patient, always think about giving the contraceptives because it do have the effect on the baby. Long-term GnRH, obviously not. And long-term GnRH, definitely it do decreases the bone calcium and vitamin D level. The progesterone only pills, obviously not. And Tibolone, that is the HRT regimen, which is given whenever the estrogen and progesterone HRT cycles are not given, that context. But here the answer goes in favor of A. So the correct answer is aromatase inhibitor, as it is recommended in women with rectovaginal endometriosis, which is refractory to the medical and surgical management. Understand, in exam, certain questions are very straightforward from your guideline. Do not bang your head in much more complications. Go with the straightforward lines and pick up the answers from the questions in order to save the time. Moving ahead with the next question, Mrs. ABC is 35-year-old and suffers from primary infertility and endometriosis. Her recent pelvic ultrasound suggests the presence of 2.7 centimeter endometrioma. Till now, so far in our slide, we have seen the cutoff of 3 centimeter. Her pain is well controlled using simple analgesic. She is due to undergo her IVF cycle. Which treatment is best suited to deal her endometrioma? Laparoscopic overhead cystectomy, definitely patient is going for IVF cycle. If you do such a cystectomy, it will decreases the ovarian reserve. Not recommended. Ovarian cyst suspension, even you aspirate, it will again reoccur. Laparoscopic ovarian cyst fenestration and drainage, again the chances of recurrence, again it will form a new cyst. And laparoscopic salpingo-oophorectomy, definitely the patient is going for IVF cycles. No point of doing the oophorectomy. In that context, the answers goes in favor of expectant management. With regards to the surgical therapy for the cyst, and Cochrane review suggests that the 4 RCTs involving 312 women concluded that the laparoscopic aspiration cystectomy of endometrium prior to the ART does not show the evidence of benefit or the expectant management. So, with the final clinical pregnancy rate, and understand one thing, whenever endometrioma is there, likely possibility in order to access your follicle, you might puncture the endometrioma. In order to avoid a further sequelae of the infection, it is always better to give the antibiotics. Moving on with the question, 36-year-old para 4 who underwent the TAH-BSO, that is total abdominal hysterectomy with bilateral salpingo-oophorectomy for a severe pelvic endometriosis that had not responded to the medical and the conservative surgical treatment. She attends a follow-up appointment complaining hot flushes and sweating. This is something which is more commonly seen when the ovary has been removed and there is a hormone depletion condition. Which HRT, that is hormone replacement therapy regime, should be considered? Understand, whenever there is absence of uterus, in that context, if you give the estrogen, there is no unopposed action of estrogen on the uterus, so no risk of endometrial hyperplasia, progesterone may not be required. But here it is done in the context of severe pelvic endometriosis. During such a procedure, if there is left out endometrial tissues elsewhere in the abdomen, if you give the unopposed estrogen, it will reactivate those lesions and that will make patient uncomfortable and maybe the purpose of surgery will not be completed. And in such a context, combined continuous estrogen and progesterone will be given. The patches, the estradiol valerate, the progesterone only HRT will not work, topical estriol will not work. But understand, when you are giving certain form of estrogen, it will reactivate certain past lesions, and in an order to have the control over that or check over that, the progesterone will be required. So women who are surgically induced menopause because of endometriosis, the estrogen plus progesterone therapy or T-balloon, which is nothing but it has the activity of estrogenic and progesterogenic, androgenic, and can be effective in the treatment of menopausal symptoms. Here I would like to quote one question. Sometimes it's been mentioned that patient is postmenopausal and she is having the libido, low libido. In that context, what you will be giving? If your patient is not on HRT, give the T-balloon. It's a composition of three: the estrogenic, progesterogenic, and androgenic contained, and that's the reason it is one of the answer. But if your patient is already on HRT regime, then yes, T-balloon will not be answer. Then just add the testosterone, or you can give the testosterone gel, and that androgen will be sufficient enough in an order to cover up the libido as a treatment option. So these are the one of the questions which is quite related to this T-balloon, very frequently been asked in my classes by my students, and that's the reason I'm giving the explanation over here itself. The European Society of Human Reproduction and Embryology Guidelines recommends that in a postmenopausal woman after hysterectomy and with a history of endometriosis, the clinician should avoid unopposed estrogen treatment. Theoretical benefit of avoiding disease reactivation and malignant transformation, which is near about 2.4% cases in the cases of endometriosis. And however, it should be balanced against the increased systemic risk associated with the combined estrogen, progesterone, or T-balloon. The Guideline Development Group, that is GDG, recommends that the clinician continues to treat a woman with a history of endometriosis after surgical menopause with combined estrogen, progesterone, or T-balloon at least up to the age of natural menopause. Which of the following statement is false? So talking about this question, laparoscopic identification of endometriotic lesion, it's confirmed by histology, although negative histology does not entirely rule out the disease. Perfectly correct. Diagnostic laparoscopy can be considered as a gold standard for the diagnosis of endometriosis. Obviously not, because as per the current ISHRA guidelines, the diagnostic laparoscopy is no longer considered as a gold standard for the diagnosis of endometriosis. Understand this Bible line very clearly. Women with may be offered the NSAIDs or oral analgesic either alone or in combination with other treatment to reduce the endometriosis associated pain. Perfectly right. It is recommended to offer women hormone treatment as one of the options to reduce the endometriosis associated pain, as we have seen so far very frequently again and again in the form of COC, progesterone, GnRH antagonist in an order to suppress the ovulation or hormonal influence. Yes, these treatment options to be given to the patient who are having the symptoms. It is recommended to prescribe women a combined hormonal contraceptives. It could be oral, vaginal ring, and transdermal to reduce the endometriosis-associated dyspareunia, dysmenorrhea, and non-menstrual pain. As in an order to avoid these things to happening in a symptomatic patient, yes, such a hormonal preparation in order to give the suppression will be given. So here the option goes for the B, which is mentioned in the guideline that yes, it is no longer considered as the gold standard technique. Laparoscopic identification of endometrial lesion is confirmed by histology, although negative histology does not entirely rule out the disease, and both the diagnostic laparoscopy and imaging combined with the empirical treatment can be considered in women suspected of endometriosis. There is no evidence of superiority of either approach, and pros and cons should be discussed with the patient about it. Women may be offered NSAIDs or other analgesics, either alone or in combination with other treatment, to reduce the endometriosis associated pain. It is recommended to offer women the hormone treatment as one of the options in order to reduce the pain after the procedure. How much is the reported risk of ovarian failure after bilateral ovarian endometrioma cystectomy? Yes, it is near about 2.4%. So it has been seen that the laparoscopic excision of ovarian endometriotic cyst wall, which is for an endometrium more than or equal to 3 centimeter, is superior to the drainage and coagulation by bipolar dithermy for treating the recurrence of dysmenorrhea, dyspareunia, and non-menstrual pain, as well as reducing the rate of subsequent surgery. While the severity of the excision or drainage and coagulation ablations might be expected, the concern about excessive resection of ovarian tissue compromising the future fertility with reported risk of ovarian failure or bilateral endometrioma cystectomy is near about 2.4%. In MRCOG Part 2 exam, yes, you will definitely get encountered with certain percentage related questions, and these are the questions which are very frequently been asked by your patient if they are coming in your UK OPDs. So what is the estimated prevalence of endometriosis in infertile women? Yes, it is near about 50%. In general population, it is near about 10 to 20%, 2 to 10% in the reproductive age groups. The next question. A 35-year-old infertile patient is classified as having a stage 1 endometriosis and was prepared for IVF treatment. After counseling regarding the treatment, she asked you some questions. Which of the following statement regarding IVF is correct? The clinical pregnancy rate for IVF is reduced in endometriosis because we understand that endometrial receptivity get hampered. Definitely it could be. Miscarriages rate is higher than the average in a patient with stage 1 endometriosis. Not very true. Ovarian stimulation could make the endometriosis condition worsen. May not be. The stage of endometriosis has no impact on the number of oocyte produced. Definitely, it's the wrong statement. Studies have shown that low fertilization rate in stage 1 endometriosis, however, the implantation and clinical pregnancy is not affected. And here the answer says that the studies have shown the low fertilization rate in stage 1 endometriosis. However, the implantation and clinical pregnancy rate will not be affected. Though the evidence level is 3, the several studies have shown similar results for IVF treatment in a patient with stage 1 endometriosis compared to the other groups with no endometriosis. There has been no indication that the miscarriage rate is increased in endometriosis, and recent meta-analysis shows low fertilization rate for IVF in endometriosis. However, implantation and pregnancy rates were perfectly normal, so it is not going to affect the clinical pregnancy rate. So the option goes in favor of E. Which of the following is not useful in decision making of surgery for a surgery to treat the endometriosis? The family history of endometrial cancer, patient age and preferences, history of previous surgery, ovarian reserve, and estimated endometriosis fertility index. Among this category, understand very clearly, the family history of endometrial cancer may not be of any use over here. But yes, patient age, as per the age, you can give a chances. If she is into the advanced ages, definitely the ART will be the one of the solution over there. Again, what she is believing that whether she is going for a natural conception at whatever the age, but definitely for a spontaneous conception, you might recommend for surgery. If there is a previous history of surgery, definitely the previous surgery might be more complicating than other upcoming surgeries. If there is a low ovarian reserve, again, you are performing surgery might be putting the ovarian reserve down, and estimated endometriosis fertility index, where the post-operative chances of spontaneous conception of patients who are not willing to go for IVF cycles. So here the answer goes in favor of A. Understand the GDDJ, that is Guideline Development Group, recommends that the decision to perform a surgery should be guided by the presence or absence of pain symptom, age and preferences, history of previous surgery, presence of other infertility factor, ovarian reserve, and estimated endometriosis fertility index. Coming to the question, Mrs. XY with chronic pain in a lower abdomen was found to have an endometrioma, which is near about 6.5 to 4.5 centimeter, and she underwent a laparoscopic ovarian cystectomy and was found to have a severe endometriosis. She wants to know the probability of a conception. which of the scored system you will use for the same. As we have very previously said, that if you wanted to say about chances of conception post-surgery, then definitely in that context, endometriosis fertility index is something which will be useful. Or wherein endometriosis 6.5 to 4.5 centimeter, definitely in that context will recommend a surgery. Device AFS scoring system will not be addressing this issue. The NGN system will not be addressing this issue. And yes, in that context, the answers goes in favor of B, that is, estimated fertility index is a simple and the robust and validated clinical tool that predicts the pregnancy rate. To identify the patient that may benefit from the ERT after surgery, this endometriosis fertility index should be used as it is a validated, reproducible, and cost-effective. There is a decreased chances of inter-observer variations in this. And this is all in general about endometriosis. In exam, the questions are more revolving around if your patient is subfertile, grade endometriosis, stage 1, stage 2, stage 3, stage 4, size of endometrioma, understand the preferences, the age, the ovarian reserve, whether the surgery will be useful modalities, whether the natural conception could be possible, whether the tubes are patent enough, whether the semen analysis is normal. So find out all this information from your questions so that you will be directing yourself towards the correct option. Now here we are coming to the end of session. Thank you, all the best wishes and the lots of love from Dr. Dinesh. Thank you for being with me on this beautiful evening. I understand this beautiful journey of MRCOG Part 2 preparation will be one of the memorable journey, and you will be always cherish this exam preparation because it makes you a good, evidence-based and knowledgeable and patient-safe doctor. Nothing is impossible because the word impossible itself says that it is possible, and still the time is in your hand. Put 100% of your efforts and stay tuned within StudyMEDIC's RRR Series for your MRCOG Part 2 journey in an order to boost up your confidence. Thanks a lot and have a wonderful evening. Thanks.